Surgical treatment of anal fistula, fistulectomy/fistulotomy, subcutaneous. The physician excises or incises a subcutaneous anal fistula. The skin and subcutaneous tissue overlying the fistula is excised or incised to open the fistula tract. The incision is usually left open to allow continued drainage. Surgical treatment of anal fistula, fistulectomy/fistulotomy, intersphincteric. The skin, subcutaneous tissue, and internal sphincter muscle overlying the fistula is excised or incised to open the fistula tract. The incision is usually left open to allow continued drainage. Surgical treatment of anal fistula, fistulectomy/fistulotomy, transsphincteric, suprasphincteric, extrasphincteric, or multiple, including placement of sedum, when performed. The physician excises or incises a complex or multiple anal fistula. The tissue overlying the fistula or fistulas is excised or incised to open the fistula tract. If the external sphincter or the puborectal muscular sling is involved, only a portion of the muscle is incised to open the fistula. A permanent suture is placed through the remainder of the fistula tract, sedum, in order to allow drainage and preserve continence. The incisions are usually left open to allow continued drainage. Surgical treatment of anal fistula, fistulectomy/fistulotomy, second stage. The physician performs a second stage excision or incision of an anal fistula. Usually the fistula tract has been partially opened and a sedum may be in place. The remainder of the fistula tract is excised or incised and a sedum if present is removed. The incision is usually left open to allow continued drainage. Closure of anal fistula with rectal advancement flap. The physician excises an anal fistula and closes the defect with a rectal advancement flap. The fistula tract is excised. An incision is made onto the perianal skin and a wedge of skin and subcutaneous tissue is mobilized and advanced into the defect created by the excision of the fistula. The incisions are closed with sutures. Excision of spermatocele, with or without epididymectomy. The physician removes a spermatocele, which is a small cyst, filled with fluid and spermatozoa, between the body of the testis and the epididymis. After adequate local anesthesia, an incision is made in the scrotum and the testis with its attached epididymis is brought out of the wound. The cyst is dissected free of the testis and excised. The involved area of the epididymis is sutured to the underlying testis and the scrotal wound is closed by suturing. Alternately, the epididymis may be dissected free of all of its attachments to the testis. The blood vessels involved are tied and cut and or cauterized to control bleeding. The freed epididymis is thus removed, a rubber drain is placed in the scrotum and the incision is closed by suturing. Excision of rectal procidentia, with anastomosis, perineal approach. The physician removes a rectal prolapse through a perineal approach. A circular incision is made through the distal rectum at the anorectal junction. The mesentery and blood supply to the prolapsed rectum is divided and the segment is telescoped out through the anus. The proximal rectum or colon is divided and the prolapsed segment is removed. The proximal end of rectum or colon is approximated to the anus with sutures or staples. Excision of rectal procidentia, with anastomosis, abdominal and perineal approach. The physician removes a rectal prolapse through a combined abdominal and perineal approach. The physician makes an abdominal incision.